Good afternoon, everyone. I, Dr. Rajkumar, presently working as Assistant Professor in the Department of Forensic Medicine and Toxicology, Sri Devaraj Medical College, feel proud to deliver the welcome address. Today's webinar, Unique Clinical Case Scenarios in Snakebite, My Published Experiences, is befitting for the Kolar district, where snake envenomation is regarded as an occupational and environmental disease. Snakebite envenoming affects mainly farmers, herders of livestock, and other agriculture workers here. Today, to deliberate this, we have the distinguished luminary and erudite scholar, Dr. B. Sadananda Naik, who is going to share his experiences in managing snake bites and saving many lives. The best part of our institution is the patrons constantly support to shape the events of our academy. With this, and with the blessings of our founder president, late Sri R.L. Jalapasar, and president of our trust and chancellor of our academy, Sri G.S. Nagaraja sir, I welcome Sri Rajendra J., our vice president, Sri Devaraja's Educational Trust, Sri Hanmant Raju KG, secretary and trustees, Dr. Raghuveer CV, pro chancellor, Dr. Pradeep Kumar G, honorable vice chancellor, Dr. DVLN Prasad, registrar, Dr. C. Ramalu PN, Dean Faculty of Medicine and Principal, Dr. S.R. Sheila, Medical Superintendent, Dr. Shashidhar KN, Vice Principal, Dr. Dinesh K, Deputy Medical Superintendent. I welcome the organizing committee members of Department of Forensic Medicine and Toxicology. I also welcome my colleagues of SDMC to this continuous medical educational event. The last but not the least, I welcome the supporting staff. Before we begin the session, let me introduce the speaker for today, Dr. B. Sadananda Naik, who has done, sir has done MBBS from Kasturba Medical College, Mangalore in 1988. Sir has done MD and DNB from Commando Medical Hospital, Air Force, Bangalore. Sir has done postgraduate diploma in medical law and ethics from National Law School, Bangalore. Sir is currently working as senior physician at Alva's Healthcare, a multi-speciality hospital, Moodbidri, for the last 27 years. Sir was the former teaching faculty at Father Muller's Medical College, Mangalore. Sir has a fellow of Indian College of Physicians. Sir has been attending national and international conferences like Toxicon, Epicon, NAPCon, ADA, EASD, IDF regularly. Sir has a good experience in handling hundreds of snakebite cases in his hospital at Moodbidri. Sir has been actively academically and has nearly 65 publications in leading medical journals like JAPI, BMJ, Toxicon, Lancet, European Journal of Internal Medicine, Indian Journal of Critical Care Medicine, Journal of Indian Society of Toxicology. Sir is presently the editor-in-chief of API DK chapter E-Magazine, API DK Lahari. At the end of session, I believe the audience will be enthralled. Welcome one and all for the webinar. Good afternoon, sir. Over to you, sir.
Yeah, good afternoon, everybody. At the outset, let me thank Professor Srinivas Reddy, Professor and HOD of Sri Devaraj Medical College Department of Forensic Medicine and Toxicology, all the patrons of eminent institutions and faculty members and delegates for giving me an opportunity to share my thoughts on this unique topic with you all. Let me begin with a disclaimer that I am no expert in snake bite, neither an expert in snakes, but because of geographical location where I practice, I get to see several cases of snake bites on a daily basis. Hence, I have published few of my experiences in leading journals. Next slide, please.
1 minute, sir. We're just loading it.
Okay. Next slide. practice of internal medicine in rural areas is little different from what we do in all metros or cities or larger towns. Here we have abundant clinical material, but we have lack of skilled manpower and medical infrastructure. And the super specialty cover, which is main backbone of all the critical care illness, which is lacking in our place. Another problem is poor availability of our patients. But these clinicians in our place, we need to know a lot of social myths and religious customs and a lot of social activities of the patients. And in this case, which I'm going to present next, is a classical example. If a clinician knows about local religious customs, definitely he'll be able to manage such cases. This is the first case scenario. In fact, this is my first publication. Next slide. In the midnight, I get a call from my duty doctor that he has got a patient who has got a snake bite, which is totally different from what cases he has already seen. He called me immediately and he was a little frightened to see that case. When I went and saw, he was a villager with a history of snake bite. He was extremely restless, delirious, and he was tachypnic. He was jerking his limbs every now and then. He had a very high temperature, body temperature was 40 degrees centigrade. He had a tachycardia, heart rate was almost 150 per minute. Pupils were dilated bilaterally. The local examination revealed mild local swelling. There was a bite mark. However, there were no blisters or skin necrosis. Next slide, please. Before coming to the hospital, patient had been to a snake healer who had administered some kind of native medication, and only then they had come to our hospital. Next slide, please. So suddenly confused the person I was, and suddenly I remembered my pharmacology teacher taking the class, as dry as a bone, as mad as a hen, as hot as a hair, as blind as a bat. I think most of you are expert in this kind of scenario. Already made up your mind about the diagnosis. Next slide, please. Yes, it was a case of atropine poisoning. The snake healer who had made the patient to drink a concoction made up of Datura ammonium plant leaves, and patient was managed conservatively with IV fluid, stomach wash, and other supportive treatment, and recovered completely, and he went home. The funniest part of the entire story was that the snake turned out to be a non-venomous one. Next slide, please. Yeah, as we see here, this is the plant which has got many colloquial names: thorn apple, devil's trumpet. You can see the thorny fruit and the bell-shaped flowers. Every part of this plant is toxic, and it contains alkaloids like atropine, iosine, scopolamine, deliriums, and anticholinergic. So whenever we come across any snake bite which is not fitting into a classical clinical features and envenomation, we need to think beyond snake bite, as we did in our case. Next slide, please. The second scenario I want to discuss with all of you. Many times you find patients coming with history of venomous snake bites, and they sometimes they bring the dead or killed venomous snakes. Some people bring alive, and most of the time they urge that they've been bitten by this particular venomous snake. But when we examine such patients, we find only the bite marks. Sometimes it could be a fang marks, but no other clinical features of envenomation. We would observe this patient for a day or so, then discharge this patient with the diagnosis of non-venomous snake bite. But now we know that there is some clinical entity called as dry bite, even in venomous snakes. Next slide, please. When a venomous snake bites, and the victim has no local or systemic or laboratory features of envenomation, it has been termed as dry bite. And it is not any unique or specific to any kind of a snake. It can be seen in any type of snake bite. Believe me, almost 20 to 60% of all the venomous bites could be a dry bite. Next slide. There are various reasons we can contemplate for the dry bite to occur in a given patient. One of them is natural immunity. So this can be seen in a tribal population who have got some genetic immunity by birth. And acquired immunity is somebody who has been exposed to a small quantity of venom, snake venom, can develop some kind of immunity against the effect of the venom. Even the venomous snake bites and the venom enters the tissues, still patient may not have any features of envenomation. Another very popular theory is that absence of venom in the glands at the time of strike. The theory says the snake has bitten some other animals or gets depleted of venom. If it bites another person, yes, that person may not get the venom. But this has been debated and it's been said that no venomous snake can get depleted of venom completely. So this is, it's been debatable and far from truth. The other thing is could be a disease of the venom glands. If the venom glands get diseased, so the venom can be defective and it cannot produce any toxic effect or envenomation. Then the coming to the fangs of the snakes, which can get obstructed due to calcification, especially this is seen in old snakes where the fangs get calcified and the venom may not reach the tissues through the fangs. And the mechanical failure of the fangs to deliver the venom from the venom sac. Sudden movement of the victim when the snake bites could result in imperfect penetration of the fangs so that the venom may not be injected into the tissues. Then it could misjudge the distance. The snakes also can make mistakes to misjudge the distance. Then the dress material which the victim wears, if he's wearing very thick kind of material or denim kind of material, or if the victim is wearing a footwear up to the knee joint, all can prevent the venom reaching the tissues. Next slide. Next. Okay. Coming to how to diagnose dry bite. The final diagnosis of dry bite is always retrospective. It means we cannot diagnose on arrival. Only after observing the patient for a sufficient period of time, only then we can say, yes, this patient has a dry bite. Patient should have presence of fang marks and snakes should be identified by some kind of experts. And if the snakes are brought alive or they bring a killed snake, we can identify the snake and we can say, yes, the patient has been bitten by a venomous snake. And there should not be any local or systemic features of any signs of envenomation for a period of 12 to 24 hours. So just like that, so retrospectively, we can say, yes, this patient has been bitten by a venomous snake and it comes under the classification of dry bite. Next slide, please. Coming to the management. How will you manage a patient who is suspected to be having a dry bite? The most important thing is careful observation of the patient for either features of coagulopathy or neuroparalysis. Even if you are sure that it could be a case of dry bite, we can't take chances. We have to do a periodic laboratory test for bleeding tendencies. A lot of blood tests are required to look for coagulopathies. At no point of time we should give these patients empirical treatment with anti-snake venom. However, the clinician gets pressurized by the relatives. It so happens that most times when they bring venomous snakes, they pressurize why you are not treating this patient, why you are simply waiting. So we have to really convince the relatives that the risk of giving antivenom really is far more dangerous than the features of snake venomization. It may come later on, which has got definite treatment available. And the second, the most important part is don't discharge the patient in a hurry. Even if you are 100% confirmed that is the case of dry bite, wait for at least 24 hours before you diagnose the patient with a diagnosis of dry bite. Next slide, please. Next slide. Yes. This is the third scenario I would like to share with all of you. Many times we used to find patients coming with this typical history of a viper bite. And they will always say, yes, we have been bitten by a viper. And we find there's a definite fang marks at the bite site, and there will be some amount of local swelling and a little bit of pain will be there. And initially, evaluation of all the bleeding tendencies, coagulation profile will come normal. After a period of few hours, when we repeat the blood test, we find the patient has features of coagulopathy in the form of decreased level of fibrinogen. There is prolonged clotting time. The blood is not clotting even after 20 minutes. That is, 20 minutes whole blood clotting time is positive. Then we would administer these patients anti-snake venom and you will wait. But still it will not make any difference. Patient still will have features of coagulopathy, blood will never clot. They will administer some more vials of anti-snake venom. Again, it will not make any difference. And many times we would change the brand of anti-snake venom. Still, it will not make any difference. All these times, patient will be totally normal. Hardly any signs and symptoms of bleeding tendency, in spite of having a lot of laboratory abnormality which suggests coagulopathy. Few times we will refer the patient to higher center where they will administer some more vials of anti-snake venom, and patient would make a good recovery over a period of 3 to 4 days. Again, patient will not have any features of overt bleeding tendencies either locally or systemically. Few of the patients would get discharged against medical advice. They would go home, and again they also will recover over a period of 3 to 4 days without any complication. So perplexed by all these developments, we went back to the literature, looked about snakes belonging to in our region, and we were convinced that this snake is nothing but a common snake, a viper, which is found in this part of our world. Next slide, please. Yes, so that was a hump-nosed pit viper, popularly scientifically known as Hypnale hypnale, a very small viper, 1.5 feet long. It has got many colloquial names, Merriam's viper. There are 3 species of this particular viper. So the important one is Hypnale hypnale, which is seen in Western Ghats of South India and in our part of the region, and also in Sri Lanka. The other 2 species, namely the Hypnale nipa and Hypnale zara, they are exclusively seen in Sri Lanka, not seen in any other part of the country. Next slide, please. So as you see here, the classical viper, which has got a typical triangular head and out body, and the snout is pointed upwards and ending in a hump. Colloquial name, you it's a popular name. Many of our patients will come with these names and immediately will be identifying this as Hypnale hypnale. And this snake moves very slowly and very lazy and sluggish kind of snake, though it can strike very rapidly. And now we know that this is as dangerous as the big, very popular 4 snakes which is seen in India. And even the WHO has included this as clinically significant venomous snakes. Next slide, please. Coming to the clinical features of this particular snake bite. The local effects. So it will, as I told you in my presentation, it comes with distinct fang marks with minimal local pain, mild edema in most of the cases. But in few cases, there can be severe local features like ulceration, blood formation, also can be seen, but very rare. Next slide, please. Systemic features of hypnale innovation also has been presented nowadays. Initially, we thought it is a non-venomous snake, but now with many reports coming, we have come to know about systemic features of this snake. The most important systemic features is what is known as hypnale coagulopathy, which is quite different from coagulopathy what is seen in other vipers. This is a delayed but persistent coagulopathy. It can be as delayed as 24 hours to almost a week. Patient can be bitten today and come back to the coagulopathy almost a week later. There has been a report of patient. Can you go back? Earlier slide, please. Go back. Please go back. Please go back. Previous slide, please.
So, 1 minute, sir. It is loading, sir.
Yes.
This is fine, sir.
Then little go back. One slide before.
Previous. The morphology identification.
1 minute, sir.
Slide number 18. 18, slide number 18.
18, sir. Yes, sir.
It can present with various manifestations. Other than this coagulopathy, like any other viper, it can also produce nephropathy, neurological features, cardiac features, GA features. Nephrotoxicity, as we know, can produce acute renal failure, like any other viper bite. But neurological features so far not been very presented so far. Cardiac features can be starting from enzyme elevations, ECG abnormalities. There have been reports of acute myocardial infarction due to this particular hump nose pit viper bite. GI involvement patient can have vomiting, diarrhea, severe abdominal pain, even hematemesis can be seen, and bleeding for rectum can also be seen. Next slide, please. Next slide.
So the previous slide, sir. Schematic representation of the previous one, sir.
Yeah. Schematic representation.
Yes, sir. Yes, sir.
So,
It is displaying, sir.
it's not going in my slide. I have the same slide in my.
Yes, sir. I think some connectivity issue, but it is being displayed, sir. A schematic representation of the.
Yeah. You can see this schematic representation. Thank you. So the most important feature about this particular snake venom is that it contains a particular toxin called snake venom thrombin-like enzyme, which, as you see here, normally the fibrinogen is fluid into fibrin monomer, and which gets converted into a fibrin clot, and that results in coagulation of the blood. But in this particular envenomation, this particular snake venom thrombin-like enzyme. It converts fibrinogen into fibrinopeptides. And these fibrinopeptides, they don't have any property to produce a blood clot. Hence, the blood remains incoagulable for hours or days together. That's a basic problem what we see in this hypnale coagulopathy. Can you move the next slide? There, management of it. Can you see the management slide?
Yes, sir. Yes, sir. It is visible, sir. Please go ahead.
Yeah, okay, I'll continue. So coming to the diagnosis, first we have to diagnose the hypnale bite. Only then we can plan for the treatment. So the classical history, most of our patients with classical history of bitten by hypnale, and more villagers are well aware of the particular snake, and they have a lot of colloquial names. So we clinician will identify these colloquial names and they agree with them, and then we think about this particular snake bite. And another important feature will be asymptomatic coagulopathy, as I described. A lot of laboratory abnormality, but no bleeding tendency at all. So identification of the snakes can be done. Even the photographs can be shown to the patients or the relatives, so we can tell the patient about this snake and they can identify the snake. Next slide, please. Coming to the treatment, you can see treatment. Next slide.
Yes, sir. Yes, sir. It is visible, sir.
Polyvalent anti-snake, which is a drug of choice in all types of venomous snakes in India. Unfortunately, this particular Indian variety of polyvalent anti-snake venom has been found to be not at all effective in HNV, that is hump-nosed pit viper bite. That's because the fact that this particular venom not being used when they prepare anti-snake venom. A simple large dose of intravenous saline can be used to prevent a lot of complications, including acute renal failure. Analgesics like paracetamol is more than enough most of the time. If a patient has serious bleeding tendencies, fresh frozen plasma at the doses of around 15 ml per kg body weight can be given every 4th hour till the bleeding tendency, other clinical features of bleeding tendency comes back, patient becomes normal. Next slide, please. Yes, this is the most important aspect of this hump nose pit. There's a clinician dilemma. The dilemma is after seeing so much of non-coagulable blood, fibrinogen is reduced, severe coagulopathy, patient is in a confusion whether to start anti-snake venom or keep quiet. So it can be a legal problem in the coming days. So, but when we know about the literature, so we can withhold our treatment, having known about hypnale, and plus there are no clinical features of bleeding tendency, systemic bleeding. So that makes us a little comfortable. And with that, another problem is that difficulty in convincing the relatives of the patient to stay back in the hospital. And as you know, patient has no clinical features barring minimal local pain. And how long we can keep the patient. So again, we'll have to really try hard to convince the patient that you have coagulopathy, you can bleed at any time, better to stay back in the hospital. That's another clinical dilemma. Next slide, please. Summarizing the entire scenario, hump nose pit viper is a clinically important venomous viper in this part of the world. Hump nose pit viper might lead to variable and unpredictable clinical progression. Hypnale coagulopathy is a definitive and different clinical entity as compared to other viper coagulopathy. The Indian polyvalent anti-snake venom is ineffective in this particular snake envenomation. Most of the cases, use of analgesics like paracetamol, intravenous saline infusion has shown a good outcome. And there is a pressing need to develop a specific antivenom for hump nose pit viper bite. Coming to the next slide. Scenario 4. This is a very interesting scenario. Snake tooth in the finger. So most of the time, we clinicians, we are worried about how to manage a snake bite, what could be the complication, whether a patient will develop a reaction to our anti-snake venom, can the patient develop bleeding tendencies, how much anti-snake venom should be given, whether patient can afford all that. And if all this will succeed and we'll be very happy about our outcome. Very unfortunately, our patient may be thinking in totally different line. He can be in a different page. And especially about venomous snake bite, there will be a lot of myths and false belief surrounding. They have their own doubt about doctor's knowledge, whether this doctor knows how to manage snake bite. And these kind of myths are not only related to uneducated villagers. This can be seen in even uneducated also. Next slide, please. And uneducated people, as well as educated, fall prey for all these myths and truths. In this case presentation, this is a classical example of people have myths and it's affecting their health. Next slide, please. A 60-year-old lady was referred to our hospital from a tertiary care hospital for follow-up. This lady was treated in a very super specialty hospital. She had been bitten by Russell's viper on her finger, and she had a very florid course. She required almost 30 to 40 vials of anti-snake venom. She went into acute renal failure, was hemodialyzed, and she had a lot of other complications. Luckily, she survived and she was sent back home completely recovered. And she had come to our hospital for follow-up. The last 2 days, the relatives told the patient was totally depressed and not at all eating, not talking to anybody. All the time she was keeping quiet. When I examined this patient, even I found the same. She was not at all communicative, kept on looking at the finger where the snake had bitten her. Suddenly I remembered my patient asking me after discharge, at the time of discharge, whether any snake tooth is still remain at the bite site. And I would always brush them aside, telling that there is no such thing called snake tooth. Even if it is there, all that will get melted by all the anti-snake venom. So remembering that, I thought she may be a victim of such myths. So when I uh, inquired about this snake tooth, she readily agreed that yes, she had doubt about the snake tooth in the bite side. In fact, a few days back, one of her relatives had come home and he asked the lady whether the doctors had told anything about snake tooth. And he told the doctors don't know anything about snake tooth. It gets stuck in the bite side, and over a period of time, the snake tooth slowly will start acting, and the skin gets blackened and get ulcerated, and whole limb gets necrosed, and it will not heal again. You have to go to a snake healer. Only he can remove the tooth. So she was totally depressed without knowing what to do. So I had a tough time in convincing her that there is no snake tooth. If you really want, I can get an X-ray and show you that there is no snake tooth. But she got convinced, and a person who came in a wheelchair to my consultation room could go back walking with a smiling face. Coming to next slide, please. A lot of myths coming to next slide, please. Next. retain the snake.
Sir, it is displaying, sir. It is displaying.
Yes, sir. The myth of the snake tooth being retained is a myth which snake healers, they exploit the patients and they make money telling that they can remove the retained tooth. And this kind of myth is seen in either both the villages and even well-educated people, as in this case. When I went back to literature and I found some facts about this retained snake tooth, and it's shown that few of the non-venomous snakes like python, when it bites, can retain its teeth at the bite side. And very rarely, vipers could also leave their teeth while biting, and that may result in local sepsis. So, it's not at all. It could be a scientific truth, but most of the time it could be only myth, as in this patient. The last scenario, the fifth scenario. Next slide, please. Yes.
It is displaying, sir. Displaying.
Yeah, that's good. We have seen patients go back. We have seen patients getting allergic to snake bite, snake venom, and getting serious reaction to anti-snake venom. But allergy to contact of the venomous snake not been reported much. In this small case report, which is not yet published but is accepted, and it is in print in a Journal of Association of Physicians of India. Next slide, please. Next slide.
It is displaying, sir. Background.
Next slide. Next slide. Case report. Can you see case report?
Yes, sir. It is displaying, sir. 35-year-old lady.
Yeah, yes. A 34-year-old lady came to the dermatology OPD with the history of severe skin lesions. And the story goes like this. This lady slept in the night, and in the midnight she was suddenly woken up, where she found that a reptile started crawling from the neck up to her face. Horrified lady inadvertently, reflexly brushed at the creature, and the relatives found that a viper, that is the same snake which I described earlier, a hump-nosed pit viper, hiding under the cot. And the relatives found no problem in the lady, and there was no bite mark. She did not have any clinical features of innovation. Only thing is she was very much scared for the entire incident, and she slept off. When she got up in the morning, and she found the entire area where the snake had crawled, severe burning pain, and there was itching all over those areas. And when we examined, there was erythematous and edematous plaque suggestive of urticaria in those areas. Next slide, please. And we investigated this lady as a routine, and all normal, including the hemogram, coagulation profile. The patient was treated like any other case of dermatitis with antihistaminic corticosteroids and skin emollients for local application. And she made a very good recovery, a period of 1 week. But I had a tough time counseling her, which a myth which is fossilized in most of people's brain, that any skin which comes in contact with a venomous snake will gradually ulcerate and it can get necrose and never heal. So that myth was still in her mind. I had a long session of counseling with her, and I had to really convince her that nothing will happen to her. So I had to ask her to come every other day to convince her that nothing has happened to her skin. Next slide, please. Coming to literature, review of literature, whether really snake venom snake contact can produce any real allergy. So snakes do not have any hair or epidermal dander. So hence, very unlikely that they can produce allergies. But most of the time, allergies are due to the substances are carried on the scales of these snakes, where they picked up from the animals they prey like mice. When they squeeze those animals, the protein from these animals will get stuck to the scale, and this protein can induce various skin lesions, allergic lesions. It is not only restricted to skin. These patients can also have respiratory illness, cough, wheezing, breathlessness. Also is possible. Another very important aspect of this entire scenario is that there's a very in thing that keeping a snake's as pet. You must have seen a lot of videos where people keep pets and put the snakes around their neck. They're playing around with pets. By a fact that these snakes could be infested by what is called as snake mites. And these snake mites, when they come in contact with human skin, can produce lot of skin lesions. So any patient who keeps snakes as pets, when they come to dermatology OPD, the dermatologist should be aware that it can be a skin allergy due to snake mites. Next slide. So thank you very much for all of you for patient hearing. I once again thank the organizers for giving me opportunity to share my thoughts with all of you. If you have any questions, anything to discuss, really. Thank you very much.
Thank you, sir. Now the session is open for discussion. The audience can ask any doubts or clarifications, or you can post in the chat box also.
Hello. Yeah, it was a good lecture. I'm Dr. Prabhakar speaking, Professor of Medicine. Dr. Sadananda.
Yes, sir. Yes, sir.
How are you, sir?
Thank you very much, sir.
Excellent talk, sir. It was an excellent talk, sir. Very highly educative, and definitely we could see your wisdom in the knowledge regarding snake. But as a physician,
Thank you very much.
As a clinician, I would like to add a few things about it, sir. Like as we regularly come across crate in this part of Kolar, there won't be any local signs of illumination. They just come with neuroparalysis, sir. Really, that we commonly see in this part of Kolar, sir. And what is your experiences regarding this? They just come in the morning with neuroparalysis, with respiratory, and we have to search for the snake, but because they were just sleeping and it would have bitten in the night, without their knowledge, they were not aware of the snake bite at all. But in the morning, they come with neuroparalysis or hemotoxic manifestations. Sir. This is one of the common scenario we can come across in this place.
Thank you very much, sir. Yes, this is a common presentation in a common Indian crate. And most time patients come in a comatose state. And it's one of the differential diagnosis for coma. And we know, we all clinicians know, will be in crate by hardly any local clinical features. And because it is almost a painless kind of injection of the fans, and even the patient may not be aware of. So one of the commonest cause of patient coming in coma, and especially in a villager who is sleeping outside. So immediately we should think of crate bite and neuroparalysis. Yeah, our diagnosis has to be first diagnosis has to be crate, and then we have to after ruling out this only we have to think about other poisoning or cerebrovascular accident.
Correct, sir. Correct, sir.
Very common. Thank you very much for enlightening.
Next thing I want to ask, sir, how long you would like, for example, we had recently seen a case of hemotoxic manifestations, sir, and the patient continues to have the manifestation of DS and continues to be from different like orifices, and we were like according to the standard like national guidelines, we gave 30 vials of ASV. But patient continues to have the bleeding manifestations, and we gave enough FFPs and other platelet concentrates, everything we gave, and we found that the patient continues to have bleed And then we made up our mind to continue to give anti-snake venoms. I think we gave nearly 60 vials of ASV, sir. And yes, sir, your opinion on that? Like how long we need to continue? For example, the patient continues to have the either neurotoxic or hemotoxic manifestations, in spite of giving the like so-called the highest dose that prescribed by the national agencies.
Thank you very much, sir. This is one of the most difficult questions most clinicians face, I think, all over India. And there is no fixed upper limit of anti-snake venom, as we know. So whenever we find such a case of severe coagulopathy, as you rightly did, so the large dose of anti-snake venom is needed, along with other clotting factor replacements like fresh frozen plasma, and it should be giving a large doses even fresh frozen plasma. And many times, people who are given fresh frozen plasma, large doses of anti-snake venom, very surprisingly, when they use a fresh whole blood, very surprisingly, with 1 or 2 bottles of freshly drawn whole blood, the entire scenario is the anecdotal report. I cannot justify how it has helped, but many anecdotal reports are there. Immediately after giving fresh whole blood, the entire scenario has been controlled. This is as far as coagulopathy is concerned. But when it comes to neuroparalysis, when we put the patient on ventilator, once we put the ventilator, the role of anti-snake venom comes down, especially after giving sufficient doses of around 20 to 30 anti-snake vials of we have given. And then we have put the patient on ventilator. And then once we put the patient on ventilator, the role of anti-snake venom will come down. We really need not worry about giving more doses of anti-snake venom.
So another question I have. There's another question I have, sir. Maybe from 5-6 years back, I read an article to measure how much like venom is being injected to the patient, and depending upon the dosage, the correction of the anti-snake venom, and like knowing the antibodies against the antigens of the snake bite, and measuring exact quantity of the snake venom entered into the body, and adjusting the dose of anti-snake venom. But somehow it has not gained the ground. You have any like literature or supporting to this, sir?
Yes, sir. This is your measuring the quantity of venom is more of a, as you already made, is more of a research as such as of now. As we know, most of the time we are finding very difficult to provide anti-snake venom. Most of the time it happens in the small centers in the PHC level, where none of our coagulable profile also is very difficult to do. At the most, we can practice this very popular 20 minutes whole blood clotting time. That's all we rely upon. So your novel idea is very good, but based on the, as it is very expensive, so we cannot really make it into guidelines where it is there. Though it is a very useful idea, but we cannot find it in the guideline because a lot of financial constraint will be there. And it is a good lab setup as well.
And last question, sir. Regarding this whole blood clotting time, 20 minutes whole blood clotting time. For example, the patient comes to a tertiary care center like ours, like when we have the entire coagulation profile at our hand. Which one you prefer, sir? Coagulation profile versus whole blood clotting time?
A coagulation profile definitely takes an upper hand over 20 minutes whole blooding time. To have a 20 minutes whole blooding time, there has to be real coagulopathy. So milder variety of coagulopathy we can pick up with other coagulopathy profile. But we can only advocate this in a smaller setup. But there are some incidences where reports where coagulopathy profile has been normal and 20 minutes whole blood count is not clotting, especially in the one which I told you, the hypnalic coagulopathy, where it's been mentioned that all those coagulopathy profile are normal. Only the 20 minutes clotting time was prolonged. In few cases, it's other way around, where 20 minutes coagulopathy is clotting, but other fibrinogen levels is reduced and D-dimer they're elevated and so many like that. So it's confusing. When you are a tertiary calcium, always better to go for a coagulation profile, and just for completion's sake, we can do a 20 minutes at the beginning, and once the patient recovers, we can always, for our practical use, we can repeat at the end of the treatment.
Yes, sir. And one last question, sir. The cryoprecipitate versus FFP, like what is your experience, sir?
The cryoprecipitate FFP has been used commonly, but as you said in your earlier case, where you used large dose of FFP, anti-snake venom, so even if it doesn't work, then we can always try cryoprecipitate. It makes some difference. You can add cryoprecipitate to FFP when you find coagulopathy is not getting control, especially when the bleeding tendency is not laboratory features, obvious bleeding tendency is patient bleeding all over the orifices. And cryoprecipitate has an additional role along with the anti-snake venom, fresh frozen plasma. Anything, sir?
Sir, I think there is some connection issue.
Any other questions?
Thank you, Dr. Prabhakar, sir, for the deliberations. And Dr. Ashok had raised their hand. Sir, Ashok, sir, please go ahead. And sir has also posted a question in the chat box. How to conclude the physical contact of snake without any eyewitness?
Yes. Because in our case report, there was a definite history of snake which is traveled, which she had felt. They have already seen the snake hiding under the cot. So that's there cannot be any other conclusive evidence other than this coincidental. So it's difficult to really, unless we have a CCTV camera in the bedroom, difficult to prove otherwise. Since the venomous snake was found immediately under the bed, so we have to be conclusive that that's the one which crawled her neck.
Thank you, sir. Thank you.
Sir, there is one more question from Dr. Chandrasekhar, sir. Sir is asking like how to confirm snake envenomation in post-mortem samples, and if there is any FSL, that is Forensic Science Laboratory in India, doing snake venom confirmation tests.
As far as toxicology concerned, I'm little not a good person to answer your question, sir. You are the right person to answer this.
Okay, sir. Sir, I'll request Dr. Rajkumar, sir, to respond to that question. Assistant Professor in Forensic Medicine and Toxicology. Over to sir.
Thank you, sir. The snake venom at the postmortem samples can be detected using many toxicological assays like radioimmunoassay, ELISA, and radioimmunosorbent assays. But while detecting the sample at FSL, still we are not sure, sir. We have to coordinate with the FSL people, then we can send the sample to concerned police, sir.
Thank you, Dr. Rajkumar, sir, for helping me out in this tricky question.
Yeah, thank you, sir.
Thank you, Dr. Rajkumar, sir. And once again, thank you, Sadananda Naik, sir, for the informative and insightful session. And a lot of information regarding the clinical management was deliberated upon, including the most important, that is the clinician's dilemma on how to manage a case, whether to go ahead with the ASV or not, and few other interesting scenarios of the snake tooth and probably the first instance of contact dermatitis being published in JAPI. So thank you, sir. Thank you for such a wonderful session. Now I request Dr. Vishal to propose the vote of thanks from the Department of Forensic Medicine.
Good afternoon, one and all. I, Dr. Vishal, take this opportunity to propose vote of thanks on behalf of Department of Forensic Medicine and Toxicology, Sri Devaraj Medical College. First and foremost, we pay respects to our late founder president, Sri R.L. Jalappaji. We would like to thank our patrons of Sri Devaraj Aras Education Trust, Honorable President, Sri G.H. Nagaraja Sir, Honorable Vice President, Sri J. Rajendra Sir, Honorable Secretary, Hanumantaraju KG Sir, Honorable Chancellor of Sri Devaraj Aras Academy of Higher Education and Research, Kolar, Sri G.H. Nagaraja Sir, Honorable Pro Chancellor, Dr. C.V. Raghuveer Sir, Honorable Vice Chancellor, Dr. Pradeep Kumar G Sir, Registrar, Dr. D.V.L.N. Prasad Sir, Dean, Faculty of Medicine and Principal, Dr. Sriramulu P.N. Sir, Medical Superintendent, Dr. Sheila S.R. Ma'am, Vice Principal, Dr. Shashikar K.N. Sir, and Deputy Medical Superintendent, Dr. Dinesh K. Sir. We also extend my thanks to other officers of the Academy. We wholeheartedly thank Dr. B. Sadananda Naik Sir, Senior Physician, Alva's Heart Center, Moodbidri. We thank Dr. Harish Sir, Associate Professor, Department of Biochemistry, for it is tacit to acknowledge Sir's focal role in conduct of the CME. We thank the faculty of Department of Forensic Medicine and Toxicology and Department of Biochemistry for the constant support. We thank all the participants of the event for making it a grand success. Last but not the least, I thank the non-teaching, photographer and technical team members who are part of this program. Thank you one and all. Thank you, sir.
Thank you, sir.
Thank you, Dr. Vishal. Now I request all the participants to turn on their camera so that we can take a screenshot.